Greetings everyone once again. Welcome to the 144th session of the online Optom learning series. And for today's session, we have with us Zach Cairns. Zach is a specialist optometrist. Currently, he's working in the United Arab Emirates. He's the deputy head of the Moorfields Optometry Department and specializes in contact lenses, anterior segment, and glaucoma. He graduated from the Ulster University in 2016 before completing his pre-registration and specialization in Moorfields, London for 3 years. And he has worked across disciplines such as specialty contact lenses, emergency cornea department, glaucoma, and probably all specialty optometry clinics and gaining that experience. He is an advocate for optometry in the wider context, and he enjoys teaching, lecturing both nationally and internationally to ophthalmologists as well as fellow optometrists. And over the past year, he has been involved in teaching medical students at the Mohammed bin Rashid University of Medicine and Health Sciences. And today, Zach is going to take us through his experience and share his tips on how to go about refracting keratoconus, what should be your starting point, when should you end, and he'll take us through his journey working with keratoconus patients. So welcome, Zach, onto our platform, and let me just leave the screen time to you.
Thank you very much for the introduction. I'm really glad to be here. And I know this is quite late for a lot of you guys a bit further east. So thank you for staying up for this. Looking just at the poll, we've got quite a good mix of students, optometrists working in clinics, retail outlets, and academic optometrists. So hopefully I've pitched this at the right level. And the idea is that everyone takes something away, a little tip, a trick, a screenshot of a good starting point for keratoconus. I'm looking forward to hopefully helping everyone. Can I just check that you can see my screen okay, Fakrudin?
Yeah.
Okay.
Yeah.
Okay. Good. So what we've got on the screen here is basically a keratoconic cornea. And we know that keratoconic vision can be variable in the in the simplest sense, from very mild cases to very weird and wonderful prescriptions. And this can be quite daunting for a lot of practitioners. I know that especially in the earlier days when I started working at Moorfields, dealing with the keratoconic patients, quite often you would look at the notes and see keratoconus and think, what am I going to do? Am I going to do an autorefractor? Am I going to try retinoscopy? And the idea of this is to give everyone a good starting point so that the anxiety isn't there whenever you do see these keratoconic patients. And refracting a keratoconic patient, it doesn't need to take a long time. That's the other thing. So what I want you to get from this is refract smarter, okay? So really think about what you're doing with these patients instead of just trying to chase your tail with spherical adjustments or, big jumps in cylinder. There is techniques to this. Okay. So a really good starting point is sort of what is keratoconus. Now, this will probably be a little bit more applicable for the students than those of us that have been practicing a little bit longer. So I think the definition of keratoconus is really important. And this is something that I think a lot of practitioners maybe sort of overlook. So it's a progressive condition. Any patient you see with keratoconus at some point didn't have keratoconus, okay? So quite often we're monitoring keratoconus, and even if you see a new keratoconic patient, you're scanning them to see, is there progression? But what you've got to remember is at some point they didn't have keratoconus, so it's progressed from somewhere. So first of all, it's a progressive non-inflammatory condition. Now, there are some inflammatory markers in the tears, but the actual cornea itself isn't inflamed. We commonly use the term unilateral keratoconus, meaning that one eye is affected more than the other. And it is always bilateral, but it can be very, very asymmetric, okay? Because we know that keratoconus has a genetic component, it's always a bilateral disease. So someone can't have keratoconus in one eye. What they can have is a lot more advanced keratoconus in one eye than the other. And then as a result of these progressive non-inflammatory bilateral corneal disease, we get this stromal thinning and this weakness that leads to the corneal distortion. Having this irregular cornea, what it means is that we essentially have a multifocal cornea. It has a multifocality to it, meaning that the warpage, or the higher order aberration, as it's sort of more commonly known, is what causes these variable endpoints. And we'll get into that in a little bit more. So the keratoconus itself has a genetic component, but there's also environmental factors. And I'll sort of go through a little bit of that later as well. But this is the real sentence that I want to bring home, okay? Progressive, non-inflammatory, and bilateral corneal disease. How common is it? So I've taken this from a few different studies. In the United States, they reckon it's about sort of 1 to maybe 1.2, some of the studies say, per 2,000 individuals. So that's, if you're working in the Western world, you're probably expecting to see roughly about maybe 2 patients a year with keratoconus. And this is just if you're working in routine, high street or routine retail practices. You're going to see roughly on average 1 to 2 keratoconic patients a year. If you're in sort of Asian Pacific, this is much, much greater. So as I'm sure a lot of the practitioners on here, you will see much more than 1 to 2 keratoconic patients a year. And it's suggested that, sort of 4 to even 7.5 times greater in some areas. Now, I work in the Middle East, and again, we have very, very high numbers of keratoconic patients here as well. I couldn't get exact numbers, but it's somewhere in the region of about 20 to 25 per 100,000 patients, somewhere in that region. So not quite as high as the Asian Pacific countries, but a lot of the genetics of keratoconus, because there's quite small gene pools here as well, quite sort of close-knit communities. I think that's probably another factor why the keratoconus levels are a lot higher in the Middle East specifically. And what about the onset then? So generally we know that keratoconus takes hold at around about the age of puberty. Now that can be different for everyone, okay? And it does tend to, in some patients or some ethnicities tend to present a little bit earlier. Okay, so we know that these sort of, especially in Indian patients, tend to progress earlier, and these are the ones that you really need to watch. The earlier the onset, the more associated it is with a higher need for surgery, and the more rapid that the progression is. Okay, so really have a look at the patient. And whenever you've got the patient there, you need to be asking the right questions. So who's the patients that we really need to be watching? Who are the ones that's likely to get this keratoconus? The eye rubbers. Now, one thing I always ask my patients, especially if it's, a first time, a first visit, and if I find out they have any asthma, eczema, or hay fever, I'm always asking if they rub their eyes as well. These are the 4 questions I will ask pretty much all patients who I would suspect may have some level of keratoconus. Now, what's quite interesting is there was a study done, and keratoconus actually affects males and females roughly equally. But generally, males present with more advanced keratoconus. Now, I can't figure out an exact cause for that, but my own theory is that generally females are a bit more restrained, and eye makeup as well probably stops them, whereas men just rub in with the knuckle and keep going. So generally, although the only data I have is that, Males and females are affected equally, but generally males present with much more advanced keratoconus. And this is one of the theories, so that it's eye rubbing is really bringing this on. And the last point there, Down syndrome as well. Really, all your Down syndrome patients, if you can, get a topography and start screening for keratoconus, because you'll pick it up a lot more commonly than you would potentially first think with these patients. Great. So asthma, eczema, hay fever, and then eye rubbing's the final question, if they have any of the above. Keratoconus. So whenever we're looking at the CLEC study, so that's basically the quality of life in keratoconus study, they looked at how this misshapen cornea really affects mental health, rule difficulty, and general aspects of the quality of a patient's life. The summary that they came up with is it affects a patient in equal measures to that what we would see in someone with stage 3 or stage 4 macular degeneration. So this is something that really, really affects a patient's life. I think what's really important from this is when it affects a patient's life. So a lot of these are sort of, late teenage years, early 20s is whenever they're first getting diagnosed with keratoconus. So generally this is, very scary, because all of a sudden, they can't see boards, glare at night. Generally they've got dry eyes. The optometrist can't figure out what's going on, or the glasses don't seem to be making much improvement. And this is something that's gradually getting worse. So whenever these patients are really kind of starting their life, so they're finding friends at university, starting new careers, maybe starting a family, all of these vision problems from keratoconus really start to take hold. So you got to remember that, these patients can be a little bit lost, and they can feel a little bit deflated from this before they turn up to your clinic. So quite often the patients come in and, it's a little bit doom and gloom, but don't worry, you're there to try and help them. And remember that we can do a lot for keratoconic patients. Okay, so the idea is that we can really sort of improve the patient and say, do you know what, look, things are difficult, but by the end of today, once we've got this refraction or contact lens fitting done, we're going to get you to where you need to be. I don't like to give an estimate of what the vision is going to be very early on. So a lot of practitioners that work with me will hear me say this, 6 over happy. Okay, I don't believe that every patient needs to see 6 over 6, but I do believe that every patient needs to have a good level of vision, so that the vision is not a limiting factor in their life. And that's different for every patient. I've got some patients that's happy in their glasses with 6/12 vision. I've got, lens patients that's maybe 6/9, 6/12, but don't want to go for a graft. So it's really making sure that you've set out a goal, and be that a task, be that a specific visual problem that they're having. And that's what we should be aiming for as practitioners. Okay. So I don't like to set this sort of vision standard. I like to say sort of 6 over happy. And again, as practitioners, we get quite bogged down with this variable endpoint, this multifocality that has came about by the higher order aberrations generally. But one of the main things that we need to remember is a keratoconic eye is irregular. Now, irregular eye plus poor tear film gives even more irregular vision. So the first thing to do is get some lubricating eye drops and make sure the patient is lubricating. I explain this to a patient as if you have a floor, and the floor is at different levels. So you've got high bits and low bits on a floor. It dries at different patches. So the high bits will dry sooner, and the low bits, obviously, that's where the lubricating drop or the tears will pull. So we want to make sure that these patients are lubricating, just so that we can get some type of stability in the refraction. And you need to be brave when you're refracting these patients as well, okay? The endpoint's not always clear, but that's okay. We're here to improve our patient's vision, okay? So I quite like this Phil Dunphy quote, spontaneous human combustion is very rare. We're here to try our best to help these patients, okay? So don't panic, okay? Some lubricating drops to start with. And then I would go into explaining to the patient why their vision isn't clear. So as practitioners, we know this, but what I would encourage everyone that sees a keratoconic patient is take out a piece of paper and draw a diagram or draw something similar to what I'm going to explain to you today. It takes 2 seconds, and you would be amazed by the amount of patients that have had keratoconus for decades and don't understand why glasses aren't perfectly correcting their vision. Okay, so I always start with, we've got the cornea here, a nice smooth front surface, and as a result, light passes seamlessly through that. If we've got an exaggerated, irregular keratoconic cornea, what happens is that the light reaches the front surface, and then what happens is you get this light dispersion. And patients can quite clearly see that that would cause a problem. If you have glasses lenses in front, it doesn't always clarify this irregular vision, because generally the issue is with the front surface of the cornea. And what does that result in? So generally you're going to have these sort of ghosting, shadows, these higher order aberrations really causing problems for the patient. And I used this example. I had a patient about a month ago, and when discussing her sort of vision goals, one of the things she said was, I just want to see the moon clearly. And we ended up fitting her with contact lenses, but this kind of stuck with me about, having that goal that was the one thing she wanted to do. And that was what I would set the bar at. That's what I want to make sure that she can see to really start living her life again as it was pre-keratoconus. But yeah, this simple diagram here that I have on screen will really, really clarify and highlight to the patient some of the difficulties that they have. Dry eyes and keratoconus. I've said this before. If you don't put in the drops at the start of the refraction, you will be sort of chasing around this, these dry patches, this irregular front surface. And you can see here from the keratoconic patient, how quickly the tears break up. So even if you're trying to take a vision here, okay, and the patient blinks, look at the superficial epithelial erosions there. You're never, ever going to get clear vision through that cornea. Okay, even with the most perfect refraction in front of the eye. Keep these patients topped up with drops. Okay, and if you want to use the uneven floor analogy with patients, you want to give these patients the best chance to really understand their condition. Now that we've got the eyes well lubricated and the patient understands what we're trying to achieve, this is the best tool you can have as an optometrist. So a tool that has 97% sensitivity, almost 80% specificity. And this is something that I am convinced is in all of your clinic rooms, a retinoscope. This is the best tool you have to pick up keratoconus. So please use it, okay? Autorefractors are somewhat useful, but having that retinoscopy reflex, you can tell, is it sphere, sill, or are there higher order aberrations at play here from the scissor reflex? So please take out your retinoscope, and this will give you, with some practice, it'll give you a really, really good starting point. But even if you're not that good at retinoscopy, just pick it up and look for those higher order aberrations in potentially a mild keratoconic patient. And basically from the studies, it showed, retinoscopy showed a clear clinical use in confirming the diagnosis of keratoconus. If you have someone that maybe in the autorefractor is picking up a little bit of astigmatism, pick up the retinoscope and some lenses, and you'll quite quickly learn, to pick up those higher order aberrations, as I said. Autorefractors have definitely some part to play. And yeah, essentially the study that I was looking at showed that basically manifest refraction and autorefraction can produce similar results in the milder stages of keratoconus, which is what we would expect, because the keratoconus hasn't advanced to a stage where these higher order aberrations are starting to come through in the vision. Now, I know that a lot of patients, the second you've taken away the autorefractor, want to know, okay, what's my number, or how good's my vision? And you need to just, make them aware that we're still doing a lot of assessing at this point, okay? This is definitely not the final results, okay? A second useful starting point. So the first one is obviously your retinoscope, which I would encourage 100%, and possibly your autorefractor. Another good starting point is, if you have it, to get a topography, or even some type of tomography as well. So this is a pentacam, but use what you have available to you in clinic. There's lots of useful information here, and for a lot of maybe students or practitioners that aren't used to looking at pentacams, this can be very overwhelming. I've highlighted a few points that I look to start with. So one of the first ones is the astigmatism. So what this does is it takes the sort of average flat meridian on the front surface, and this is just the front surface we're talking about here, and the average flat meridian and steep meridian, and take them away. So it takes away the diopters. And you can see, so basically, oh, 1 second. Let me just get this up. Yeah, so if you look here, 42.1, 45.7 is your flat and steep meridian, and that gives us an axis of 3.6 diopters. The K max, this gives us an indication of what's the steepest point of the cornea. So we know that most corneas are roughly 40 diopters. This keratoconus has increased that to 46.8. Generally, if it's sort of below 50, we would put it in the sort of mild category. Once you're sort of 65, 70, then you're getting into more advanced keratoconus. This is only used as a very rough guidance to how advanced the keratoconus is that you're dealing with. We've got the front surface astigmatism. The back surface astigmatism, generally because of the nature of keratoconus, because it's stretching forward, as the front surface steepens, so does the back surface, okay? And I would expect some of this astigmatism to probably cancel out some of the front surface, okay? Because one will be a sort of a mirror image nearly of the other. But these give you an idea of where the axis is. If we just look at the front surface here, so what I've done is I've taken the front curvature of the right eye and the left eye. You can actually see where the sill is. So a lot of us have, know with the rule, against the rule astigmatism. We're using those same principles. We can tell that, a good starting point here would be in the right eye, roughly 120 degrees axis. Left eye, roughly about 75. Okay, so we're just trying to line up the the meridian, which we're going to put the axis along for the negative cylinder. And again, sorry, I probably should have specified I will be working in negative cylinder throughout this whole presentation. Generally, what you expect is a cylinder that's slightly temporal, and that tends to be what you find with keratoconus. If with your retinoscopy or your autorefractor, you cannot find a starting point, at all, I would suggest these as your starting points. +2 with a -4 sill. So essentially that is spherically 0, the mild keratoconus. The moderate keratoconus is actually a little bit plus, but from working in keratoconic refracting clinics a long time, if you can't figure any starting point, either put in the mild or the moderate prescription, depending on the K max, and this will give you a really good starting point. From here, you're going to do big sphere adjustments, big sill adjustments, and you would be surprised at how accurate or this starting point will get you. If you're going to screenshot anything, screenshot this. This is a really, really useful slide to have. And all of our Optoms have this up in their clinic room. As I said, use it at 90 or slightly temporal. Once you put this into the trial frame, the thing that a lot of practitioners forget is that patients can see out their eyes better than we can see into them, okay? So ask the patient to actually put their hand on the trial frame and tweak it. So tweak it so that they can find the cylinder axis. Once they have got it to whatever that may be, 120, 150, take note of that. If later on in the refraction you can't find a distinctive endpoint, go back and just double check the axis that the patient first suggested. The steps in sphere and sill will be dependent on the vision, okay? But that's what it will be with every refraction or low vision patient that you see. But do that and then try to refine it. And as I said, go back and double check the axes that the patient suggested or where they felt the most comfortable with. This doesn't need to take a long time, okay? So 5 to 7 minutes per eye, and sometimes not even that, okay? And please remember, refract, if they're a contact lens wearer, refract after the lenses have been removed. If someone wears RGP lenses 7 days a week, there's no point in refracting them once they've been out of lenses for 2 days, because it will totally change the prescription. And if you're prescribing glasses, wait until after the contact lenses have been finalized to then re-refract and just double check. Scleral lenses with adequate vault tend to be less prone in inducing this blur post-removal. But again, just if you're sorting out contact lenses and glasses, get the contact lenses sorted first and then review the glasses afterwards if they're going to be a consistent lens wearer. Pinhole. Working in a lot of different clinics, the pinhole tends to be a little bit variable. Some people like to use it with keratoconic patients, some people don't. What I will always do is at the very end of the refraction, if the patient isn't happy with the vision, I'll put in the pinhole lens, which will sharpen up the vision generally by quite a bit. And then I'll say, well, this could be the potential that we might achieve with a contact lens. So if they're not happy with the glasses, use this as an opening to maybe suggesting contact lenses. Now we've finished the refraction, remove the pinhole lens. When prescribing, we're trying to reduce the cylinder as much as possible, but still keep that spherical equivalent. The difficulty comes, do we prescribe the full prescription? Do we prescribe a balanced lens in the more difficult eye? All of these are right answers. If you work in a hospital where you have the ability, or a practice where you have the ability to easily reglaze the glasses, I would be more keen to go for the best possible vision. At the end of the day, that's what we're trying to give these patients, is the best possible vision. The best possible vision, but the best possible comfortable vision as well. So if we do have to reduce the cylinder a little bit, or if that does mean a balanced lens, if there's very, very asymmetric prescriptions, do that. Let the patient sit in the waiting room, let them have a look at their phone, go for a walk, and try out the prescription as well. Keratoconic patients are used to having really, really strange vision, okay? As you can see in the photo below, they're used to tolerating these higher order aberrations, this astigmatism at oblique angles. So generally, they actually cope much better with the refractive results than you would assume a patient going into a 3 diopter oblique sill or 4 or maybe even more than that. So as I said, go in with caution, but be confident enough that you're here to get the patient the best vision possible. And if that does mean a small change or a reglaze, have that discussion before instead of after, okay? And let the patient know some of the potential problems that there might be facing. I cannot stress this enough. If you have a dispensing team with you, it makes a big difference, okay? I know some of the hospital settings or the academic settings tend to send the prescriptions away. If you do that, try and find someone that you can recommend, someone that that you can maybe call and advise, this is a keratoconic patient, there might need to be reglazes, and work with a really, really good dispenser. This is one of your best allies whenever you're refracting these keratoconic patients. You really want to make sure that the appropriate size of lens is picked, centration is correct. And another thing is the patients always come back and they'll say, oh, but if I look at a strange angle or tilt the glasses or turn them upside down, I get better vision. And you really need to have a dispenser that's confident enough to say, oh, do you know what? That's actually quite common. The reason why that's quite common is because of this sort of, this difficult multifocality of your cornea, and you might get these little spots of clarity, but our aim is to give you the clearest vision through the center of the lens. So you've got to have someone with the confidence to, really discuss with these patients their eyes. Okay, so be brave whenever you're doing this as well. BVD is vitally important. It's important with all patients, 4 diopters, sphere or sill and above. But, especially with these keratoconic patients, we really want to make sure that we're getting them looking through the center of the hard refraction that you've just done. As I said before with the diagrams here, if the glasses aren't giving good vision, it could be an opportunity to open up for contact lenses to say, look, we can give you this new pseudo cornea or this new smooth optical surface, which will in turn then give you this crisp, clear moon or this crisp, clear image that you want to see. So, if the refraction isn't giving you the vision, look, open up, talk about some contact lenses as well. In the left-hand image, we've got the irregular cornea underneath. This was an impression contact lens. So essentially we used their irregular cornea and then built a lens on top of it. Okay, so there's lots we can do for these patients. Don't let them think that refraction is the ultimate or the only option they have. We've got lots of options to try and improve vision. Try with glasses first. Get the patients in early, so really good history and symptoms. Get them cross-linked, and a lot of them will do really, really well with glasses or soft contact lenses. And as I said at the start, these patients do come in generally quite apprehensive. The vision is difficult for them, so you really need to make their day. Try really hard, and the patients will appreciate that you're giving them your best effort. Okay, and I'll just finish on this. Treat everyone like it's their birthday. So treat everyone like they're that special patient. Give them the time, and they'll definitely get the results. Perfect, and that's everything from me. If there is any questions, I'd love to answer some of them. And I believe we've got some polls as well.
Yeah, thank you so much, Zach, for that very, very informative sharing. I think I like your point of retinoscope. That's the tool which you need to have, and please use it.
Yes.
Can't, right?
I know. I agree. So many people have it there and use it as a pen torch. It's so useful, and it's definitely a skill that even if you haven't used it in a few years from university, pick it up, start using it on patients.
Yeah.
A lot of people that don't do the pediatric clinics, kind of lose a little bit of touch with the retinoscopy, but it's a really, really good tool for screening, and that's what I hope people take away from this.
That's right. That's great. I think I totally, completely agree with that. And, we have been being into academic, we have been telling our students retinoscope is something which you need to pick up and it's something which you will have to use every day and you should be using every day.
Yeah.
Right?
I know. I think it unfortunately fell into the category of the ophthalmoscope. And I think people forget about them together, but the retinoscope's the one that you really need to keep to hand,
That's right. Okay, great. So just one question, Zach, as for your experience, I was just thinking, do you prefer to do a spherocylindrical retinoscopy, or do you think that, when neutralizing the reflex, do you think using a sphere method works? Do you have any thoughts on that?
So I always use sphere cylinder. Again, okay. That is probably more just because I've sort of always been taught that way. Okay. It seems to be, well, from my impression, it seems to be a lot of the doctors seem to use the sphere method. But I just find that you can't refine the cylinder axis quite enough with that. That's the one difference as to why I lean more towards the sphere cyl. Because if you just hold up that sphere to begin with, you'll get the cyl axis, put in the cylinder at the axis which it appears, and then at the end I always just go back to just the sphere to really double check and make sure that it is exactly. So yeah, that's my choice. But But
that's right. As you rightly pointed out, I think ophthalmologists use a lot of sphere method to get the powers at the different meridian. But I guess getting the axis is pretty much challenging in that we might not know the particular axis for that. Yeah.
Well, if you do a sphere retinoscopy, as I said, ask the patient to find their own cylinder.
Yeah.
If you do put that cylinder, ask them to really refine it down, and don't be scared to get the patient involved. The more involved they are with their eye care, the more likely they are to come back. Because at the end of the day, you're creating that relationship where it's I'm involved in your eye health, you're involved in your eye health, and it lets the patient know that that this is a little bit of trial and error, okay?
Yeah.
And that it's something that might not be perfect, and they'll see themselves by changing it, like, oh, actually, it's a little bit better here, it's a little bit worse there. They can see their vision changing, so it gives them a much better idea of the outcome, I think.
That's right.
Can involve them.
True. I think that's a wonderful point. I think it's good to get them involved, and they have been seeing all these ghost images, and the moment they see the image without the ghosting, they'll be very appreciative of that, right?
Yeah, it's amazing. It's one of the most rewarding things, keratoconic patients.
That's great.
In all aspects.
Is there any reason why, you mentioned about the inferior temporal? Do you have any idea on why does that always happen? Is there any thoughts on this? So
we know that basically the keratoconus is from stromal thinning, or basically a lack of adhesion between the stromal fibers. Inferior, I would guess that's probably mostly just due to gravity. If things are stretching out, they're going to go down a little bit. I've heard a few different theories, and nothing concrete on this as well. Generally, whenever people are rubbing their eyes, generally it's from below as well. That's something that's been suggested. Nasally, I'm not sure. Generally, if you look at a normal corneal profile, the thinnest point is generally a little bit inferior and nasal anyway. So is it maybe just exacerbating what's already the thinnest point of the cornea? Is probably another, it's another theory that's been tossed around as well. Honestly, I don't have a perfect answer for this. But the fact that you're realizing that it is generally inferior temporally gives you a really good starting point as well. So although I don't have the perfect textbook answer for that, I've got a few ideas as to why it happens, but I really can't give a definitive.
That's right. Yeah. As you said, if we know it's, majority of them have that inferior temporal inclination, it would be very helpful for us as a starting point. At least we know where to play around, rather than going that 360 degrees. Yeah.
And look, if you do have a pentacam, as I said, look at that as well. Just kind of see where the cone is, where you're aiming for. Don't go in blind.
That's right.
What's keratoglobus?
Yeah, and I would just like to add on something. Of course, keratoglobus is I think you will say, but any difference you find where refracting a keratoglobus, which we say it's a more of advanced corneal ectasia, versus people who you see in the earlier stages?
So keratoglobus, basically, as the name suggests, it's a general sort of thinning of the cornea and ectatic disease. Generally, it's not as focal as keratoconus. So what you'll find is a large bulge instead of a focal thinning or apical high point that you'll get in the keratoconus. Just from generally what I've found in clinic is the keratoglobus patients tend to do a lot better. So because the astigmatism generally isn't as high, because the whole cornea has protruded a little bit, I find that the refractions are a little bit easier.
Okay.
So keratoglobus, it is its own disease, okay, and it is separate from keratoconus, but it still comes under those ectatic diseases. So keratoglobus, pellucid marginal degeneration is another one, which we haven't spoke about. And then obviously keratoglobus is the sort of third main, corneal ectasia that you're going to see.
Great. The other question is when you're looking for the axis and all of that, do you think the Jackson's gross cylinder is something which will help you to refine that, the JCC, or do you have any experience, or do you prefer to use Tinopic slit for that?
So I always use my Jackson cross cell. I've got 025, 050, and -1. And yeah, I will always go to a Jackson cross cell. I've always had really good results, but I'm sure there are other techniques out there. You know, this lecture was just to give people a starting point, and a few of my practice tips and tricks. You know, there are definitely people that have been refracting keratoconus a lot longer than me, but it was more just to start a conversation. And you know, if anyone else has any tips, you know, we'd be more than happy to hear them as well. So you know, contact me or just pitch in here. You know, write them in the comments.
That's right. So that's what we want to create, you know, to start the initiation. If you have some more tips, I think everybody will be happy to know them. So if anybody in, you know, attending this call, or even if people who watch later on the YouTube, you can put down your thoughts, and, you know, we learn, everyone can learn together, right?
Yeah. Happy to hear.
Yeah, that's right. Just a small this thing I would say. I think I try to use Tinopic slit probably when you want to get the axis right, whereby, you know, when you put the Tinopic slit, and usually in those cases, because, you know, you're constricting the amount of light entering, so the halos reduce, and it can tend to give you a better idea of the axis. Sometimes, yeah.
Well. Yeah, if it gives you that better starting point, try it out. Try it out with these patients. You know, there's different techniques work for different patients as well. You know, so if you are a bit stuck or getting a bit down in the weeds, try something else. You know, see if you can get a better end point.
Yeah, and I think I would come back to the first point where you started the presentation. You say, don't get afraid. You have to do. You must do something for the. So you know, there's no right or wrong. The whole idea is make them 6 happy patient, right?
Yeah, that's what I mean. Like you're there to improve the vision, and as long as you explain that at the start to the patient, you know, they're always happy just to come on. Let's work through this together and see what we can do.
That's right. Yeah. And just as the idea when you're talking about the axis, do we usually take it from the axial map of the cylinder axis?
So I can go back to that slide if you want. Take it from here. As I said, the axis will change across the cornea. So basically, you know, you can see here that it's not exactly 120 degrees. Okay, so basically, because the cone's dropped inferior temporal, you know, you're getting a little bit more, like probably, you know, maybe 100. You're probably on about 90 here. Just use it as a reference point. As I said, there is no perfect starting point with these patients, but I find that the pentacam's useful just to keep on hand. So it means that if there's no other good starting point, and you can use them here as well. So you can see there the axis was, well, that's the flat meridians, 20, 25.9. Where have you got your steep here? Anyway, if you know that the flat axis is 25.9 here, you can almost just add that to your 90, and you've got what, roughly 120 there. So, you know that's the steep axis is the opposite. You know, right. It's something I find useful.
Thank you so much. I think that's really important, and topography can give you a lot of clues. So axial map is the map which we, you know, look for you know, getting the axis, and use the steep meridian axis. That would be something which we will be focusing on. Any thoughts on duochrome test? Does it work well, or you don't prefer to use it? Is there any thoughts on this?
I don't really use duochrome so much in these patients. There's a few things. One is generally, if you're, you know, the duochrome we're obviously using on our younger patients. Okay, I find it's a lot more susceptible in, you know, if someone's vision 6.6 keratoconic, yes, I'll probably use it then. If the best I can get them to is 6.9, you know, you can be an 050 out, and red, green, it's not going to make much difference to the patient. I would probably use it up until someone's maybe 20, 25 if they've got good vision. After that, I don't really rely on it as much. And how useful is the information? In that, these patients have a lot of higher order aberrations that's going to throw this test out massively. The duochrome is generally a specific test. We're deciphering between red and green, which is what, 0.50 diopters apart. Some of these patients, you'll take out you'll put in a 4 diopter cell and they'll read 2 letters more. So these patients have really weird vision. It's not predictable and it's not a normal refraction. So a lot of these finer tests like duochrome, even +1 balance, you can't really get down to the 0.25s. So an 0.50 out in a keratoconic vision, they're probably going to see just as well. So don't get too caught up in those.
Yeah. I think I like that point. Don't get too caught up in doing that changes to get that duochrome balance. Of course, I mean you can start doing it, but don't rely. It's not something which a normal vision, normal cornea would appreciate, basically, right?
Yeah, absolutely. Yeah.
And the principle of the test being chromatic aberration. So aberration, and patient already is having aberration. So it's gonna not work that well as you would do this thing. So people tend to spend a lot of time doing duochrome to get that balance. You can, but don't get carried away, right?
Well, this is what I mean. So if a patient's seeing, let's say 6.6 or 20/20, so let's say they're seeing really good vision, but they're seeing 3-letter E's. Okay, they can still see 6.6, but they're going to have shadows, halos, and a variety of in-between aberrations that one could be focused on the red, one could be focused on the green, and it doesn't give you any useful information at that point.
Yeah, that's true. All right, a couple of more questions, Zach. You did give us a very good tip on drawing and explaining the patient about what keratoconus is. Do you want to highlight any more points which, when you talk about glasses versus contact lens to the patient, any useful tips on that matter?
Yeah. So generally, what I'll do is I'll do the refraction and I'll sit the patient in the waiting room and say, look, or just say, go for a walk. We work in quite a big hospital area here, so I'll say, look, walk around, see what you think. The patient will give you feedback if it's good enough. Now, don't forget that the clinic is such an artificial environment. Unless they're an optometrist by trade, they don't look at sight test charts. Okay, so it's a useful objective measurement, but it's not useful in the real world. Okay, so send the patient away or ask them to make up a cheap pair of glasses and go and try it out. They'll give you back feedback either in the clinic or quickly after if the vision isn't good enough.
Yeah.
Generally, you'll know yourself if the patient's happy with the end point, okay? But don't forget that to really get that crisp, clear 6.5 vision, you're probably going to be going for lenses. I would say anything more than, probably 45, 50 diopters of keratoconus, you're going to want to be thinking some type of either keratoconic soft lens or start thinking about something else. It's really the mild patients, the very mild patients, or the unilateral keratoconic patients that get on well with glasses.
Right. So just a connecting question with this, do you always give contact lenses an option to all your patients, or only you think that whenever the vision is not something which they achieve, only then you give them the option?
Generally, I'll suggest it to most of my patients.
Okay.
The patients that I wouldn't suggest a hard lens to, I'll always suggest a soft lens. Now, I think that's probably more my practice than anything else. So even if someone doesn't have keratoconus, I'm a big advocate of, have you thought about soft lenses? So I suggest that almost as part of my practice. The reason for that is that everyone's got more than one pair of shoes generally. You've got the welly boots for the garden, you've got the high heels for going out, and people like the option. So even if it's not for a strictly refractive purpose, just having the option of putting on some contact lens, even if they're soft lenses, and these mild cases generally, a silicone hydrogel, it has a little bit of, higher modulus or rigidity to it. It actually covers up a lot of these very small aberrations as well. So you don't need to jump straight in with the Kerasofts or the hybrids or the, RGPs. Sometimes just a silicone hydrogel can just mask enough of that prescription and gives them a really good option of a daily lens just to wear once in a while.
That's right.
Yeah. So I don't wait until they've got bad vision to start suggesting contact lenses. I always start the conversation a little bit earlier.
Yeah, and I think that's a good point, because understanding that keratoconus is kind of a progressive condition. So sooner it may progress slowly, or as you were saying, some ethnicities might progress slower, some might progress faster. So at some given point of time, they are going to be in a stage where they might need some different mode of vision correction to achieve best VA. So starting early is definitely a good option and a good idea, right?
Just planting the seeds. A lot of these patients you're going to see every 6 months or a year. So, they'll go away and think, oh, do you know what? Quite often it's the nighttime driving's really started bothering me, and that's the one that I always think, well, you know what? I think contact lenses might be a great option for that.
Yeah.
But just plant the seeds early. Contact lenses are fantastic. You can take these patients from counting fingers to 6'5" in, 2.5 seconds when you insert a lens. It's really a modern day marvel, contact lenses. So.
Yeah, right. That's well said. Couple of more here. Again, this is not exactly related to the talk, but I just wanted to take this since you have that experience in working with keratoconus. So what should we propose for corneal cross-linking treatment? Do you think that it should be done for all patients? Or again, this is something which you discuss with a few category of patients? And what should we do? Should we prescribe glasses, contact lenses first, or directly do the cross-linking first?
Yeah, it's a really, really good question. So cross-linking, whenever I used to work for the National Health Service back in the UK, to be eligible for cross-linking, we used to have to prove that the condition has progressed. So we would monitor them over 6 months or a year, and once maybe the K max or the K1 or K2, once the values have changed or gotten worse, then we can say this condition's getting worse, we need to cross-link.
Okay.
That was the health service. If you work in a private setting, any keratoconus, I would just cross-link on initial consultation. The reason for it is if they have keratoconus, you know that they didn't have keratoconus at some point.
Yeah.
And by definition, you know that it has progressed because it had to come from somewhere. The only exceptions to this is, anyone who is, probably at the age of about 30 onwards, I'd maybe monitor them for 6 months or a year. I'd maybe be a little bit cautious. I always put myself in the seat. If I had keratoconus at 30, I would probably want cross-linked because I wouldn't want it to get worse. And the other thing is, if they're getting one eye done, advise them to get it done in both eyes, because it's not a very comfortable procedure. I've had patients describe it as it's like a carpet burn in your eyes. Like it's epithelial removal surgery, what we're doing here. It's sore for a few days, and you don't want them to have one done and then they have to come back and get the second one done, because it'll take them out of work for longer.
Yeah.
They'll just not be happy. So if it were up to me, I would, cross-link on presentation if possible, as long as the corneas aren't too thin and things like that. And after that, then, discuss the glasses and the contact lenses. Sometimes I'll take some scleral measurements and send them through for cross-linking, with the idea that by the time we get the lenses, they can come back for the initial sort of collection pickup once the epithelium's healed. I work quite closely with a few manufacturers. So as long as I write that in the notes and it's covered under warranty, if I do need an 050 or an 075 change in refraction, that's fine. You're fitting the sclera, not the cornea. So as if you're fitting a scleral lens, it shouldn't change much anyway. But that's just me trying to hurry things along a little bit and kill a few birds with one stone.
Yeah. And I think our patients would appreciate that, rather than waiting for so long. And if you do something like that, if it is possible, and you very rightly said, if you are looking for scleral lens as an option, it won't really change much after the cross-linking, because the cross-linking is done on the cornea and the scleral tissue remains intact, right?
Yeah, that's what I mean. So for the surgery, all you're doing is removing the epithelium, cross-linking, and then the epithelium's growing back. So, 50 microns, as long as you've already got a good clearance of 150, you're never at risk of that. And also it means that the patient can go from, my vision's difficult with keratoconus to, well, I've cross-linked to stop it getting worse, and I've got good vision from scleral lenses in the matter of a month or two. You can get this ball rolling quite quickly, because a lot of these patients have been passed from one practitioner to another, or they've moved country, or, and they've heard varying opinions, which is the other one. I know a lot of people find they've got keratoconus and someone suggests go and get a graft. And, you can refract them up to 6.6, 6.9, and, there are other options out there. Some places seem to be a little bit more sort of graft keen. I think as an optometrist, one of our jobs is to keep people away from the sort of corneal surgery if possible. I'll never stop someone from doing it, but if we can get great vision with glasses or contact lenses, I think that the need for graft is becoming less and less. I know it used to be 1 in 5 keratoconics would be sort of up for a graft at some point in their life, or would progress to the stage where they need a graft. But with the amount of cross-linking we're doing now, the grafts are becoming less and less prominent, definitely in clinic.
Yeah, and just to for the interest of the audience, I think you have the privilege where you are working in a big hospital setting where you have the ophthalmologist there, and you can always co-manage together, where you can let the ophthalmologist decide on whether cross-link or not. But let's say if you are working in a private practice where the ophthalmologist setting is not there, it's just an optical setup with a primary eye care. Do you think we should be referring our keratoconus straight away once we detect at the first stage, or we should monitor and then refer? What do you think would be a good idea?
Personally, I would refer. Okay. Now, I would do a routine referral, because this is something that progresses over years, okay, not over weeks or months. I would refer, if you have a topography, send it with them. Because, although there will be some variation between machines, it's really good to know, this was done 2 months ago. Let's have a look and see what the values are differing by. If someone has, as I said, the big 4, so asthma, eczema, hay fever, or rubs their eyes a lot, these are the patients that I would really stress, look, let's get you in before this rapidly becomes worse. And note that down in your referral letter. This is a patient that has about 10% have family history of keratoconus, or any of the other atopia. And you bring them in, get them cross-linked as soon as possible. And why would you not want to stop this? That's sort of my approach. If you can, just get it done. Yes. Especially if someone's 17 with keratoconus, it's only going to go one direction.
Yeah,
it's not going to get better.
Yeah.
I would send them in on presentation.
Yeah, that's a very good point. I guess it's really important. Sometimes when we are into private practice, we don't have that privilege and all of that. So, but we need to also understand, as you said, the earlier you detect, we know it's going to go one direction. Why not get the cross? Right?
Yeah, as I said, 30, 35 would be the patients that I would monitor.
Okay. Great.
Onwards.
Right. And something on retinoscopy, any tips, when we have keratoconus patient, you see a very dim reflex. Have you encountered this, and how do you overcome this? Any tips on this?
Generally, a dim reflex, be that from keratoconus, cataract, whatever the reason for the dim reflex, just reduce the working distance. Okay. It's something that it's a really, really simple tip. Instead of working at, a meter plus, just bring it down to 50 centimeters, use that +2 working distance to your advantage by getting that little bit closer. Keratoconic refractions, what you'll find is the apex which is not always where the pupil's looking through. So generally the apex will be a little bit lower and a little bit temporal, as we said. Try and look a little bit higher. Try and look through the center of the pupil, and that'll give you much more accurate results than trying to refract through the apex itself. So go a little bit higher. The other thing is that if you're using the more peripheral pupillary reflex, you'll get better results, because keratoconus generally tends to be worse in the sort of center or sort of nasal temporal, that sort of 1 to 2 millimeter central cornea. But if you can look just outside that, you might actually think, oh, well, whatever it's doing in the center, the outside's all going with. So I need to add more plus, or the outside's giving me a big cylinder in this axis. So try not to use that strict apical center. Try and look slightly off as well and go a bit closer, and you'll get better results and lots of practice. That's the other thing.
Have you tried switching the mirror? I'm just thinking, I read somewhere that, plane to concave and concave to plane. If you switch the retinoscopy, this thing.
What I do is I would do a little bit more sort of dynamic. So basically, because I do a lot of pediatrics as well, I always work at 50 centimeters. Right. And once I think the point is neutral, I'll go back a bit more to get a negative, forward a bit more to get a positive. Okay. So that's how I generally know that I'm roughly in that territory anyway. So yeah, once you get it and you know your working distance and you're confident, just pull back a bit and see if you get a negative result or an against movement. It's good help.
Yeah, that's great. I think that's a great tip. Adjust your working distance and see whether you are getting that reversal to just see whether that was neutral or not as well, right?
Yeah.
All right. Just one last question. It just came up and I'm just putting it across. Have you experienced patients with trichiasis or entropion have any association with keratoconus? Anything which we need to look for?
So what I've found is that these eyelid disorders can cause corneal scarring. Absolutely.
Yeah.
Generally, the scar, it's actually the opposite of keratoconus. So what happens is whenever you've got obviously the cornea is being scratched continuously, it will scar. And then scar tissue, if you've ever looked at it on your skin, it's actually tight. It's very tight tissue. And what it does is, instead of keratoconus, which bulges forward, the scar pulls in. So what you'll get is actually a flatter result as of the scar. Okay. So the keratoconus isn't caused by the trichiasis or the entropion. I know I said ectropion here, but the entropion, I think, is kind of what was meant.
Oh, yeah.
Keratoconus is its own corneal disease, but these eyelid problems can cause scarring. And actually, I've got quite an interesting, I hope you don't mind, I've just got one photograph, which is to do with this, which I think would be quite, let me see if I can find it. Okay, so obviously we've got a lot of scarring here from an unknown infection, but she actually wasn't here for this eye. So this is the pentacam of that eye. Okay, and you can see here that the scarring inferior has caused this big flat area. Yeah. Okay, the keratoconus has caused steepening, the infection has caused flattening, and this patient was seeing 6.5 unaided.
Oh, that's great.
So obviously through this little small part, the vision was actually really good, because I said, okay, do you want this eye fitted? And she was like, no, my vision's great in this eye. Why would I want that? I want the other keratoconic eye. And I just, was amazed. So basically keratoconus causes the steepening, sort of the warmer areas. Infection causes the flatter areas. And sometimes they just beautifully balance out to give you 6.5 vision. Not a recommended treatment for keratoconus, but I thought it was quite an interesting case whenever you were talking about scarring.
Yeah, that's good. And I think these patients would be very difficult to counsel as well, because they are seeing well, and they would always say that, why should I? As you said, the patient said, I don't want anything on this eye. I can see 6.5. Right?
And I was quite happy. The other eye was quite mild keratoconus, so a Kerasoft lens, and she was unaided Kerasoft lens. Good vision in both eyes. But yeah, so I think what the main point that I wanted to say here was the trichiasis is generally that sort of scarring, which generally flattens the eye, instead of keratoconus, which steepens it.
That's right. Yeah. So that's great. Thank you for sharing this with us. I think this is something which is unique. You won't see it every day, or probably you won't see it in the lifetime as well. It's a very special case which we see today, right?
Yeah, definitely. Keep note of these patients as well. The other practitioners, if you have the ability to photograph or scan, or because you'll look back and discuss these with other practitioners.
That's right. Yeah. Just to get your opinion or anything pertaining to this, if we say about spectacles, do you have any preference towards having any material, or going for an aspheric lens, or do you want to have any additional coatings or something like that which would help?
Honestly, not really.
No?
Is the short answer. So with these eyes, we want to cut down glare as much as possible. So in general, an anti-reflective coating is always, a good idea, especially if they're complaining of these nighttime glare symptoms. I would suggest an anti-reflective coating. Okay. Material design, these patients aren't going to want big, thick glasses, but you've got to do it at the right time. So if this is a patient that has been wearing glasses before, the prescription hasn't changed much, then yes, if they want to get 174 high index lenses, no problem. Mm-hmm. If the patient's going straight into their first time, -3.5 sil glasses, I would say, look, don't bother with coatings, materials, just get something that works and make sure it works before you start spending a lot of money on designer glasses and expensive lenses. It depends which stage the patient is at in their journey of refraction.
That's right. I think very well put. We need to understand that as well. And I think some slides where you were saying about, the idea of the patient, where how the patient thinks, we should also understand the psychology of the patient as well. And this again relates, spending. It's gonna, if you say that, you get that best 1.74, get that aspheric, get that, best coating, and then he puts on, but I just see the same,
Don't set yourself up like that,
That's right.
Be very careful with your word choice, especially when people are spending a lot of money on spectacles, and be careful what you're promising them.
Yeah, that's right. Great. So thank you, Zach, for that wonderful sharing. I think it's been a pleasure to have you onto the platform. Thank you so much.
Yeah, thanks for having me. Okay, and good night, everyone. Thanks for tuning in.
We do have an e-symposium planned for the World Sight Day, which is on the 14th of October. And this is in collaboration with Vision Science Academy and online Optom learning series. Both of us have come together and we have an e-symposium. So please mark your calendars. We'll be sharing more details via the email. So thank you everyone for tuning in. Thank you once again, Zach, for that, giving your time and for that wonderful sharing. Take care, everyone. See you next week. Be safe and bye-bye.